DiLorenzo, Dr. DiLorenzo, you might have seen on the flyer. So this is just a little bit about me. That's my family, my two boys, Zach and Zaid, and my husband. So I'm a full scope family medicine physician, so that means I do babies, women, everything in between. So newborn to geriatric care, basically. My focus though is kind of more maternal child health, so women and babies, and focusing on that relationship as well. I graduated from UCF for undergrad, and I did my bachelor's in molecular and microbiology and biotechnology. I went to medical school at Ross, and then I did my residency at Orange Park Medical Center in Jacksonville, Florida. And then I did a women's health / OB fellowship at University of Tennessee Health Science Center. So like I said, these are my kind of special interests, especially maternal child health. I like to do procedures, and that was kind of part of what drew me to OB is, you know, delivering babies and doing C-sections, and it's very procedure heavy. First topic is contraception. So this is a slide from the CDC, or Center for Disease Control. So I'm going to kind of form the presentation from most effective contraceptive to least effective contraceptive. As for the contraceptive devices, some of them are not just used for birth control, but they're used for a lot of women's health issues. As OBs and family practice, we actually don't have a very big toolbox for hormones, and so sometimes, you know, we'll have young girls, 16-year-olds, having really heavy periods, and we'll talk about using, I like to say, a hormonal pill, and the dad immediately goes, "Did that mean birth control?" And I'm like, no, we're not using it as birth control though, we're using it to treat her bleeding. So these are the medications really we have to help with a lot of gynecologic issues, not just for contraception. But we're going to focus the talk today basically for these for contraception. So the most effective at the top are what's called like permanent sterilization, and then the IUDs and the implants. And then the second most effective is that second tier. So this is about like 93 to 97% effective with best use. Everything at the top is greater than 99% effective. And then at the bottom, you have a very high chance of getting pregnant with just using that. So those are ones I don't recommend a whole lot if someone really does not want to be pregnant. For permanent sterilization, these are the greater than 99% effective. So that there's a male version and a female version. So the male version would be a vasectomy, and then the female version would be a tubal ligation. So vasectomy. So this is just kind of to show you the anatomy. So basically what this procedure does is a small incision made in the vas deferens. That is right here, and the sperm travels down when the male ejaculates. And so by cutting off this connection, which is the same process basically we do with the tubal except different anatomy, we can stop the process from sperm going to be ejaculated. And so what happens with the sperm here? Well, it's still produced, but it just dies in the tube. So this is a really simple procedure. It's a in-office procedure. A lot of urologists will perform it at outpatient surgery centers or in the office, depending on what resources they have. And then and when I lived in Tennessee, actually, even a lot of family practice doctors did it in the office, but so far I haven't met any that do this. But it's done under local anesthesia. They don't have to go under, completely under, anything like that, and it takes about 2 to 3 days recovery. So for the women's part, for the permanent sterilization, so this is a tubal ligation. So there's two different pictures here because there's really two different types of ligation process that can happen. So I'm going to start with this one because this one is a little bit less common but is becoming more common. So this one is called a salpingectomy. That's where this whole tube is actually completely removed. And this is most commonly done at the time of a C-section. It can also be done laparoscopically at a later date, or you know, if a woman decides that this is the type of sterilization she wants. Some women have had ectopic pregnancies, meaning pregnancies in the tube, because that's the most common place for ectopic pregnancy to occur, is actually in the tube. So they don't want that to ever happen again, and they want that whole tube removed. Sometimes it's therapeutically done to save the woman's life, because if a pregnancy does occur in this tube and it bursts, they tend to take an OBGYN usually tends to take the entire tube with it. So that's one that can be done. Some of the reasons too that might be done is because there's a small percent of women that will develop ovarian cancer and what's called the fimbriae. So these little, this right here is the fimbriae, so these little kind of like tentacles that kind of like hover over the ovaries. And because they're so close to the ovaries. So some ovarian cancers can be here. And so for that reason, some women prefer to take the whole tube, because if they know they're never going to use it again, they want to reduce their risk of cancer as well. They might have a family history of ovarian cancer or something like that, and they want it out. But the more common ones are these. So again, there's a lot of ways to do something. So there's 3 different ways here shown. So I commonly do this way in a C-section, where I just tie and cut. So I try to take a portion from here and take a large portion, because again, if we take a small portion, we're going to increase the risk that a woman could have an ectopic pregnancy. Yes, you could put those tubes back together, but the point of this is really actually permanent, and is not really to get the tubes put back together. So if a woman wants that, that is what I would recommend. You can cauterize a tube, where basically they burn it or they ligate it. This is commonly done in a laparoscopic, or where they put the cameras in, if they do it not during the time of C-section basically. And then also the banding or clip, but I haven't seen that way really used as much anymore. Another one that I wanted to talk about here that I missed was what's called an Escher device, which is a coil inside the tube. This is recalled from the FDA, and so some women still have it, but nobody is putting new ones in that I'm aware of, because the FDA has eliminated this device. But that was another form of permanent sterilization, because it basically destroys the integrity of the tube with this coil. Okay, so the IUD. So this is a really good device for a woman who, say they're, sexually active and they don't want to have a period they don't want to have a pregnancy for maybe 3 years, 2 years, 5 years, maybe even up to 10 years. Maybe they're decided they're kind of done having kids, but they don't want a tubal. They don't want that permanent form of sterilization. They don't want to undergo a surgery, so sometimes there's risk for certain women there. So we have a lot of options for IUDs now as well. So the Paragard is the only one that is no hormones at all in the IUD. And so the Paragard is commonly used for contraception. It's not really used for any other GYN disorders like abnormal bleeding or something like that, because it really doesn't serve any other purpose but fertility. So that works by basically it's covered in this copper material, and these copper ions help prevent prevent ovulation, and they help keep that uterine lining thin, similarly to basically this hormone here. And it's a pretty large device, so I don't ever recommend this one unless a woman has been pregnant before, because the uterus actually grows, it stays a little bit larger no matter what, even after you've had a baby. And so for nulliparous or women who have never been pregnant, this is a kind of large device, and if it's improperly placed, it can actually kind of embed in this area. And so that's usually not ideal. I most commonly probably use the Mirena. It's been around the longest for the hormonal types of IUD. And they all use, as you can see, the same amount of, it's called levonorgestrel or a progesterone hormone. So there's no estrogen in this at all. It's only progesterone. And then I really like this infographic here because it tells you all the ways of how the IUD, the progesterone one, works, but really this is all progesterone contraceptive. So the depot shot, progesterone only pills, these all basically work the same way, where they thicken the cervical mucus so it's harder for those sperm to get to the uterus at all because there's this thick cervical mucus there, and then helping inhibit sperm from reaching the fertilized egg. So that's the mechanical part of the device, so that these would be the same there, just that it's a large device, and as you can see it kind of has these wings and it kind of almost even, you know, blocks the tube area. And then it actually helps thin the uterine lining, so it keeps that lining nice and thin, so really an embryo can't implant into that that lining. There's the Liletta, Kylena, and Skyla. So the Skyla is the smallest of the devices, so this one I would probably use most commonly in a woman who has not been pregnant before. And so say, you know, for a woman who maybe just recently got married and wants to not, you know, she's going to medical school, she doesn't want to have a baby for a few years, but she still wants to be intimate with her husband, so this would be a really good option. So you don't have to remember to take a pill, you don't have to go to your doctor every few months and get a shot, so there's definitely a lot of benefits here for IUDs. And like I said, the all the hormonal ones can be really commonly used for other disorders besides contraception. And I love these because they last a long time and they're over 99% effective. So I've seen one person ever get pregnant with an IUD, and she happened to get pregnant with twins, and she was just very fertile. But it's a very, very, very rare to ever see somebody get pregnant with an IUD. So the next one is the Nexplanon. So this is an implant that's placed in the arm. So this picture isn't great, but there's kind of a pointy edge there with the, it's metal, and there's a canal inside, and then the device is inside that canal. So the oral contraceptive pill, it's 97% effective with best use, but really it's about only 93% effective. And this is because a lot of people miss their pill. A lot of people will take it at different times. They're not consistent with the times they take it. And there's two types of pills. There's, well actually there's like hundreds of types of pills, but there's basically kind of two types. Is the ones that are what's called combined oral contraceptive, so that's estrogen and progesterone containing, or progesterone only. Now the progesterone only pills are even less effective, but some women may choose to take those because if they're breastfeeding, they don't want that estrogen, or if they've had a blood disorder where they can't tolerate estrogen, they're at increased risk for blood clots or something like that. So they may opt for a progesterone only method. How does the pill work? So the pill helps to stop ovulation, again, thins that uterine lining because of the progesterone, and then thickens the cervical mucus, very similarly to the IUD methods. There are a lot more contraindications to the pill though, so meaning that a lot of women cannot tolerate the pill at all because of chronic diseases they have, and so, or symptoms, migraine with what's called migraine with aura, that's a reason not to take the pill. So there is a small increased risk of stroke with that combined oral contraceptive. So you want to really figure out which method is best for you based on your personal history. So one method is not best for everyone based on you know, if you want to be pregnant, when you want to be pregnant, and then all of your medical history. So if you smoke and you're over 35, this is a method that we don't even prescribe at all, because again, your risk of heart attack and stroke actually goes up a lot because you already have a little bit higher risk there. I like the pill because it's been around a long time and we know a lot about it, but for those women that I know don't want to be pregnant for a few years, I really try to emphasize how great those other methods are, the IUD and the Nexplanon. Okay, so then you kind of have this batch of everything else. So these are all kind of on the same efficacy line as the pill, but I would definitely say that after the IUDs and the Nexplanons, the pill is probably really the most common one I prescribe. And then probably second after that, maybe Depo. And then the NuvaRing and the patch, I counsel my patients about, I offer it. For some reason, it's a hard sell, maybe based on familiarity with it. Maybe they don't know somebody who's tried it. So as far as the Depo, so that is an injection. It's progesterone only, and it's every 3 months that you have to repeat that injection. So it kind of gives your body a large initial spike of progesterone, and then over that 3 months time, it kind of slowly dissipates out, and it goes below a line that's effective, which is why you would need to do it every 3 months. And again, it works the same way though as all those progesterone pills. Sometimes we use it as treatment for very heavy bleeding, where other things have not worked. So it's really good at stopping bleeding. It's so good at stopping bleeding, a lot of women on it don't have periods at all. So, and that's one of the other things with the IUD as well, is because it's that local progesterone only effect, a lot of women will not have periods after it, which is normal, and we don't get concerned about that at all. The next two, the patch and the ring, so those are both combined. So just like the combined oral contraceptive pill, they're estrogen and progesterone based. And so they come with all that same risk of having the estrogen based birth control, but basically in just a different format. So, you know, the patch I don't think is great for Florida in the summer, especially it decreases in efficacy if women are very obese. So for obese women, I really won't give it at all because I can't guarantee how effective it's going to be. And then, you know, I try to tell them that in the summer, you know, you tend to sweat, and it has just more risk of kind of peeling off. Sometimes it doesn't adhere very well because it's like a nicotine patch. It's this an adherent base. And then it just shows you in this image like where the places you can put it, so your upper arm or back, and then the buttocks or the abdomen area. You can put it on the upper chest, but you don't want to put it anywhere near the breast. And this is the NuvaRing. Some women also, oh, and the patch, I just want to say that's, so basically you would put it on once a week, every week, and then the 4th week you wouldn't put a patch on, so you would basically have a period at that time. You could keep putting patches on if you didn't want to have a period at all, but the recommendation for, like, the manufacturer recommendation is that's how it's prescribed, is 3 weeks on and then 1 week off. And then the NuvaRing is similar, where it's a ring every week and then 1 week for a bleed. But basically, it's almost like a thick little rubber band, and you just insert it in the vagina, and you actually can't mess up how you put it in. So it looks like this person's inserting it perfectly, but it will just form around the cervix. You can't, there's no wrong way to insert it really. Once you move around, it will just fit where it's supposed to fit. I haven't had any women have any issues inserting it or anything. That was always one of my initial concerns, but everybody seems to do a pretty good job with it. So, and then you can take it out intercourse if you like. If you like, you can leave it in so you don't forget about it. It really doesn't matter. Okay, so Sedef actually brought up a good point to me when we were initially making this presentation about cancer risk, and just to kind of review this slide, because some women have been told that you can never get pregnant once you've used a birth control, or you know, there's a higher risk for cancer if you use birth control, or there's a lot of side effects. Well, there are some studies that show a very, very slight increased risk for breast cancer and for cervical cancer. So with the cervical cancer, it's kind of interesting because this association though is also with women who tend to be more sexually active and have more partners. So I don't know technically really about that cervical cancer risk. It's not generally in one of my counseling, you know, that when I talk with a patient, it hasn't been a part of my process, and I don't know any OBGYNs who really counsel their patient about a small increased higher cervical cancer risk. And the breast cancer risk, I thought that was interesting because that was not something that I had heard before. And again, it's not in any counseling that I've heard any of our OBGYNs do, but it is a small percent, 7%. So the main point I actually want to bring is these lower risk of all these other cancers. So the 30% lower risk of the endometrial cancer, the 30 to 50% lower risk of ovarian, and the 15 to 20% of colorectal. So colorectal cancer is one of the most common cancers in the country, and using hormonal contraceptive actually significantly decreases the risk. And there's all kinds of new ongoing studies about IUDs and lowering cancer risk as well, because basically your body is kind of not in any type of hyperactive estrogen or progesterone producing state. The hormonal method that you're using is kind of controlling that, so there's not ever an excessive amount, and I think that has a lot to do with those women who are already increased risk for those cancers. And so some other forms of contraception. So there's fertility awareness based methods. So this is the calendar or rhythm method. So basically, I don't know if anyone's familiar with like the period app on your phone, where you put in when your period is and it'll actually tell you when you're ovulating. So this is kind of using that method by not having sex at the time of ovulation. So it's usually from the first day of the period to day 14. 12 to 14 is when ovulation occurs, and then so not having sex during that time period. When I was reviewing this method, there's actually a significant portion of time that it says not to have sex to avoid a pregnancy. So I just don't know how practical that is for most people. And again, you know, this depends a lot on the type of patient you have, if they are okay with the pregnancy but they're just not currently really planning on one, because it has a lot of flaws to it. So there's male condoms and there's female condoms, as well as diaphragms. So male condoms, I mean, I think everybody is pretty familiar with male condoms. You've seen them. They're the only method to also help prevent sexually transmitted diseases. So that's really important in my realm of the world, because that's one of the big things I worry about for women. And then also prevent pregnancy. But as for the diaphragms, I didn't put this up there because I had forgotten about it, because it's an older method, but basically it's like a circular shaped device, and it's actually fitted to the woman, so it's almost like a cup, and they can use that method, so that it's similar, I guess, to how the Nuva ring would be inserted, but you need to have it fitted by a doctor and prescribed. And then you would only insert it for sexual activity and then take it out during. So it doesn't offer any of the hormonal type estrogen or progesterone, but it's a barrier type method. And then withdrawal method, which would be before ejaculation occurs, stopping intercourse. So before that moment of ejaculation. And I know Manny's going to talk a little bit more about that, so I'll leave the rest to her. And that's it from my end. Woo!